It's going to be a rota case. So let me ask the panelists regarding the rota, how often they are doing it right now, and how useful it is. I know Dr. Mohamed Agred had a great experience on rota, so we'll start with Dr. Agred.
I probably do about 60, 70, up to 80 cases a year. If I think I need it, I always use it.
Okay. Dr. Shalmani?
Less than that, maybe 20 cases a year. Yeah.
Okay. Dr. Nurisa?
Well, in AF, we would do a few cases a year. The current position would be known to the persons there, but presently in my own center, I do not do any rota cases.
Dr. Tayyib?
Currently, hospital I'm practicing, we don't have rotablator, but prior to that, a year ago, I would do like once a month, definitely. And I think that's important if you just want to be a rota operator to stay in practice also. You just need to wait for the final lesion to do on it. So.
Okay. ठीक. Hello, Fahim and Paul.
Hello.
Good afternoon.
Hi.
Hi, Bashir.
Good evening and Assalamu alaikum and greetings from Tan Tock Singh Hospital, Singapore.
Walaikum assalam.
Some of you might know me. My name is Fahim Jafri. And with me I have my dear friend and colleague, Dr. Paul Ong, who is the director of the cardiac cath lab here at Tan Tock Singh Hospital in Singapore. So we have a very interesting case to show you. We are very grateful for the invitation. And I personally thank Bashir, Dr. Afsar Raza, Dr. Amber Malik, and many others I know who are involved in this fantastic endeavor for inviting us. And it is certainly an honor and a pleasure to be here.
Same here,
So,
Fahim.
as I said, we have a great case.
I would like to, let me introduce you to the panelists, and right from the beginning, I really want to thank you and Paul for accepting this invitation, and not only that, but sponsoring this transmission as well. We are really grateful. I have a panel of experts here. I think most of them probably Fahim would know. Dr. Mohamed Agred is from UK. Dr. Shahzad Munir is also from UK. General Noori is from Pakistan. Professor Nadeem Hayat Malik from Pakistan. And Dr. Tayyib Mohyuddin from Pakistan. So we have a great panel and we look forward to your case.
Well, hello to everyone. As I said, we have a great case. Before I ask Paul to introduce the case, I just want to introduce our team. We have Dr. Ho Yi Hua, who's helping out with the IVUS interpretation. We have my two colleagues, Dr. Jason Lowe and Tim Watson, who are at the back end helping with the logistics. I have Dr. Chia Yuwoon, who's helping with patient management, including sedation, because this patient is required to be sedated. And we have a fantastic team here in the cath lab. Our nurse Hui Min, Neil as a radiographer, nurse Kavita, Adam, and am I missing somebody? Jayan. Okay, and outside at the control panel we have Raj and Tony managing the hemodynamics, etc. So let's move on to the case. Paul,
Okay,
do you want to go ahead and talk about the case?
Can I have the PowerPoint? Okay. So thank you very much for inviting us to demonstrate this case. So I have a lovely gentleman, 54-year-old gentleman who came to us. He is a heavy smoker, got a history of diabetes, hypertension, But the most important point here is he's got a background of chronic kidney disease with baseline creatinine of about 210. He came to us about 3 weeks ago with an NSTEMI and found to have his circumflex occluded. We also noticed that he has severe right coronary artery and LAD disease. After the angioplasty, his creatinine jumped up to about 237. The echo at the time demonstrated a poor EF of 30% with regional wall motion abnormalities. Can I have the next PowerPoint? So you can see here the circumflex was occluded and a drug-eluting stent being put in to open up the circumflex. Next. So you can see that the RCA also have critical lesion. We're probably going to stage this right coronary artery at a later date because of the contrast issues, okay? But today we're hopefully to demonstrate to open up the LAD. As you can see, there's a mid-LAD severe stenosis, and it's really heavily calcified. We'll show you more pictures later on. Next slide, please. So these are the cath lab, these are the laboratory data. Okay, hemoglobin is okay. The creatinine have returned back to baseline at 212 as of last week. Next, please. And let's have a look at the indications. You know, in the guideline, it would say that this patient belongs to someone who is intermediate to high risk, and in the presence of NSTEMI, we should be staging the other vessels in roughly about 3 to 4 weeks' time. So I think this is what we're going to do today, and I'll be happy to hear what the panelists have and the view on this particular patient and how we're going to do this.
Right, so Bashir, does the panel want to give us some thoughts, what they think of the case? We can show you another angiogram if you like of the LAD, or we're happy to listen to your thoughts and see what you folks think.
Okay, let me ask
Why
the
don't we show the
panelists,
angiogram that we've
what
done
would
just
they
now?
do.
Actually, that's a good idea.
I'll ask the panelists' opinion, and is it the same?
Next.
You did the circ, and that's after the circ?
Yeah, this is the pictures that we just taken for you. So you can see that it's a very heavily calcified. The LAD is basically been outlined without contrast.
Okay. Yeah, it's really heavily calcified, and bifurcation also involving the, although the diagonal doesn't seem to have that much disease, but there is some disease at the ostium. Okay, Dr. Agdate,
Yeah.
what would you do in
Yeah,
this
agreed.
case?
Hello, Fahim. Hello, Paul. Yes, I mean, he's got an ejection
Hey,
fraction of
Ryan,
30%.
nice to hear your voice.
Can you hear me?
Fahim, can
Yes,
you
you
hear
can
us?
hear it.
Yes.
Yeah, EF is poor.
Okay.
EF
Correct.
is 35%,
Sorry,
correct.
one can argue
Yes, I can
that
hear
you
you.
need any data on viability or ischemia in these territories. But I suppose this is probably because of his inferior, or because of the infarction that he came in with the occluded circ. Looking at the angiogram, it's heavily calcified.
Yes.
Although the
And
calcium
the anterior wall is moving.
Yeah.
Yeah, the calcium does look adventitial, and I think this is probably the advantage of IVUS, to see where it is. In the middle segment, it might require rotablation. Proximally, I think it's all adventitial, so it's probably not going to cause you any problems. But I certainly, if I'm going to do this with angioplasty, I will use
Okay.
rotablation.
Can we go forward to? So since you mentioned about IVUS, this is the run where we try to push the IVUS catheter down. This is a Volcano Eagle Eye, and you can see that we are not able to push this across the stenosis.
I mean, this is an eagle eye, which
So
is
we
a
have
white
limited
bucket.
pictures of IVUS views. Correct.
It is, yeah. But it's quite a good test of see how things can track. So maybe we can ask Dr. Ho to show us the IVUS picture. Can we demonstrate, show you what the limited run of the IVUS looks like?
So can you see the IVUS picture now?
Can we switch to the IVUS? Yeah.
So this is the cross-sectional area of the IVUS where the catheter got stuck in the mid-LAD. And you can see quite a significant calcium, arc of calcium from 3 o'clock to 12 o'clock. So involving 3 quadrants of the vessel. So I think probably we will think of rotablation to modify the plug when we proceed with the PCI. So these are quite limited views. You can see also there's also significant plug burden in the vessel. And as we are pulling back into the prox LAD, and you can see the increase the big size in the prox LAD, measuring about 4 in diameter.
So any other thoughts from the panel?
I think the question is going to be, Shahzad, what are you going to do with the diagonal? Are you going to wire or retreat or do something to that, or just...
Hi, Paul, Fahim. very interesting case. There is certainly disease at the ostium of the diagonal.
Yeah.
I'd be inclined to keep this simple. You've got a very heavily calcific LAD, that's the priority.
Yeah.
I suspect the diagonal will be fine. Another issue is renal protection here. You know, there's a very
Just
real
keep running, William.
risk of
Run
acute
two.
kidney injury, the contrast-induced kidney injury, and have the guys taken any maneuvers, steps to minimize the risk of that?
Professor Nadeem, you have rota?
Yeah.
So that's a,
I was just wondering whether it would be worthwhile doing an FFR to the diagonal, because it looks like a significant sized vessel, and I'm not sure whether it should be left as such without any protection. Is it, I mean, angiographically we see significant disease, although it could be misleading due to the calcium as well. So, I mean, I'm not sure what the
Okay.
operators think.
So can we have the PowerPoints again?
Yeah, Nouri
Yeah.
sir?
yeah, so those are all very valid points. I think
Yeah, I think an interesting case. I think one is the renal protection, which has been mentioned, because the first time when they did an angioplasty on the circumflex, the creatinine went up to 3.4, or it's back to baseline. So I think we have to use minimum dye. Without a rotablator, what I would do is to use an NC balloon, or maybe if that doesn't work, use a cutting balloon. And I would wire both. Now, without using the cutting balloon, I would wire both the diagonal and the LAD, and then stage this procedure and put in a state straight away.
Fahim, you have seen that a lot of like
Thank you.
cath labs
Thank
in
you.
Pakistan don't have rota, or they don't have that much experience in rota. Do you have any advice
Yeah.
for those labs? What should they be doing in such cases?
I think your only option then is to either use try to dilate it with an NC balloon. Sometimes an NC balloon may not cross off the bat, and you have to start with a compliant balloon and then gradually step up, and even use a cutting balloon. You know, our thoughts were that, you know, the lesion is heavily calcified. Some plaque modification, albeit not debulking, would help in the case moving forward. And in some ways, that is a renal protective measure, because what happens is that if you're going to use rotablation, you're actually going to make subsequent device tracking and subsequent maneuvers easier. And so that's one of the issues with this case. There is renal insufficiency. We have very well hydrated this patient for the last several hours. The patient has been receiving IV fluids. We have waited till the creatinine returns to baseline. We agree that this is a bifurcation lesion. We don't think that the diagonal has a lot of disease. We may think about doing putting a wire down the diagonal after we've done rotablation. And then what we might do after we've done the rotablation is to do another IVUS to see how things look and see what the vessel sizing is.
Yep.
And we'll sort of may
Yep.
seek your input at
And
that
with
point.
the IVUS, we'll probably be able to cut down on the
Right.
contrast. So can we just tell you what equipment we're using today?
Yeah, uh-huh. We don't have the orbital device here as yet, so I won't be able to comment on it. I do know that it's fairly effective, but we don't have experience with that.
Okay.
So let's just show you the setting. If you can focus on here, we have
So it's a
a
radial approach.
5-in-6 sheath, and Paul, maybe you want to tell us why we used it.
Yeah, this is the second time we're using this radial artery, because the last time was only about 3 weeks ago. So we really want to minimize the trauma to the radial artery. So we chose a smaller size catheter, a smaller size sheath. So this is a 6-in-5 sheath. Allow us the outer diameter of this sheath is equivalent to a 5 French sheath, but then the inner diameter can actually accommodate a 6 French guide. And I think in this case, Fahim, you chose a Droid XB3.
We chose an XB3, so it's an 0.72 inner diameter, and that sort of gives you a little bit more lumen to work with if it's a bifurcation, and if you have to do something complex at the bifurcation. It also serendipitously allows us the option of using a 175 burr if we need to. We're hoping that we won't have to, but at least that option is there in our pockets if we need to. And so for those two reasons, the 0.72 lumen Adroid XB3 is a reasonably good choice. So I think we'll sort of start with the rotational atherectomy,
Yeah.
and we can maybe focus
Yeah.
on.
We have already wired this artery with a run-through wire,
Yes.
and we exchange the run-through wire out with a rotor floppy wire. Because we're planning to do rotablation, we are not able to wire the diagonal at this stage.
At this
So
stage,
we're going to modify the plug first, get the IVUS catheter down, and then we see it from there. So Fahim is going to demonstrate how to do the prep this rotor.
All right. So as you can see, many of you may have. Go ahead. We're going to start with a 1.5. No, we're going to go straight with a 1.5, and you can make the argument. No, I agree. You can make the argument that even a 1.5 is too small, and maybe a 1.75. But I think we're going to go with something simple and something less aggressive, and then we see how things go, and we take it from there.
Fahim,
So
sorry.
just in terms of this, in terms of.
I have to say I probably would have started
yes.
175 because looking at the diameter on the IVUS, it's 2.2 by 2. It's quite big.
Yeah.
Of course, you're going to have some wire bias, which will
Right.
hopefully help you to kind of modify the lesion.
Right.
1.5 probably going to pass through the lesion without even touching it.
Well, let's see. As I said, I mean, that's a valid point, and we certainly acknowledge that, and we did consider going straight with a 175, but I think, with this EF being low, 30%, going with a very aggressive burr right off the bat can sometimes, lead to some degree of instability. But it's a point well taken. Certainly, a 175, as I already said, may have been a reasonable thing to start with, and we do have that option because we have an 072 lumen guide should we need to graduate to that. So we'll proceed with this, and then IVUS and see how things look. So just in terms of prepping the.
Sorry, do you still use cocktail?
Yeah, so we
or-
have a cocktail of Rotaglide.
Yeah.
We have transvenous pacing in place. We tend not to use venous access for the left. For the RCAs, we more often than not will do so. So at this point, for this patient, we have a transcutaneous pacer in place, and hopefully, that should keep things quiet and steady. So moving towards the, starting the rotablation, there are a couple of things we have to be certain of. We have to make sure that the system is well hydrated, and if you can focus over here, we have the cocktail dripping, and the cocktail in our case is made up of Rotaglide and heparin. Other institutions use Verapamil and nitroglycerin. We find that Rotaglide works well for us. We have to make sure that the advancer is nice and loose, and we're going to test the burr and test the system to see if the rotation is functioning all right. So what I'm going to do is I'm going to swap the pedals with Paul, because unlike Paul, I can only work with half my brain at a time. So we're going to use two persons to do this. So if you can focus over here, I'm going to start the burring outside the patient to see if the system works.
We're going to set at 160, right?
We're going to set it 160, and that is a matter of debate. Some operators go up to 200, others go much lower. A good median for us is 150 to 160. So if you can focus on the rotablation console, you can see that Raj is setting the speed that we want. 160 is about where we want, and so now what we're going to do is we're going to make sure Paul is already checked and made sure that the wire, that the brake inside the system was functional. And what the brake does is it clutches onto the wire when the burr rotates and doesn't let the wire rotate. Because if you imagine, if the burr is rotating at 160,000 per minute and the wire starts spinning, you're going to lacerate the artery.
Okay, we're good to go.
So what we're going to do now is go in,
Dynaglide,
and we're going to
yeah.
go in on Dynaglide. So Dynaglide is a lower rotation speed, and we're going to Dynaglide the burr up. And so, can you guys see the angio?
Yeah.
Now,
What kind
Drop
of
down,
speed
one,
you
see the
use
different one.
nowadays? High, low?
so we're using 160, 160,
Dr. Agret?
150 to 160. But as I said,
The evidence from the studies that shows 140 to 145 reduces the least amount of feed and platelet aggregation.
Okay.
But this is in the old time when the clopidogrel
My hand.
Exactly.
therapy and all this wasn't used. Nowadays, for smaller burr up to 1.5, my speed is about 180 to 185. For the bigger burr, I'm about 150 to 160.
Sure.
So now,
Right.
Well,
And that's a valid point. I said that there's a lot of controversy. All of the studies on speed are older studies.
I think we're just going to start this case, the rotor. You ready? Okay. So you're going to loosen it? Yeah, loosen it a little bit. Okay. So ready to go. Okay. Ready? Mac 1? Okay, go for it.
So we use a pecking motion to try to cross the lesion. And as you can see, it's not really sailing through. There we go. So it took a couple of pecks for it to go through. And we sort of stop and then watch, look at the hemodynamics. I don't know if the hemodynamics can be displayed for the audience. The blood pressure is nice and stable. The EKG is nice and stable.
Heart rhythm is very stable, no block.
Patient is stable, so far so good. So I think we're going to give another run or two. Yeah.
Sorry, one of the recommendations is not to adjust the speed when you're burring. I noticed that there's some adjustment to the speed. Is this something you do regularly?
No, it's not adjusting. No, we don't. No, it's not. The speed isn't being adjusted. It's we usually keep it at whatever we set it at.
Finish or you want to
One more. We'll do one polishing run. So we've crossed quite easily, and we're just going to go now and do a polishing run. Flora, please. And now I don't feel much resistance. It's going nice and easy, so I'm happy with that. So at this point, we're going to now go ahead and get the burr out. And I'd like to know what you all think. Do you think we should go up with a Dynaglass on? Right?
Okay, go for it.
Should we go up with a higher burr? Should we IVUS? Should we, what do you guys suggest?
I'm going to focus on my hand, yeah.
And if you could focus on Paul's hand as he is getting the burr out. So it's basically a push and pull motion. And at my end, I'm just waiting for the wire to pop up and the wire's out. Okay?
Fahim, can I suggest that you do an IVUS? Because there's a pathognomonic or very typical appearance of the calcium after you do a rotablation. If it's been effective, you see a reverberation artifact from the calcium at the breaks.
Okay?
And that usually tells you that you've made some inroad into the calcium.
Give me the Sean Blue again.
Okay, that's a good point. That's something we have.
You've gone through it very easily. You've made that look really easy for him. So the concern is the burr big enough for the vessel or not?
Yeah.
But I think IVUS will certainly give you that
I'm
information.
going to bring the wire back a little bit.
Just want to take a quick picture, make sure everything is hunky-dory and good.
You know, when you're burring, is you want to make sure that you're not having any deceleration of your burr. So, what I generally tend to do when I'm burring is have somebody shout out the burr speed to me at regular intervals to make sure that the burr doesn't decelerate. I think that's important to do.
So 50-50 contrast?
what kind of speed you use?
Again, it's very dependent on the lesion. I tend to do high-speed burring. If you look at some of the data from the Japanese will burr at sort of 200k plus. I have to say I'm a bit reluctant to burr at that sort of speed. I generally tend to burr at around 175 with the smaller burrs, maybe dropping it to around 165 with the 175 or a 20 burr.
Well, Nadeem, do you have rota at PIC and do they do it frequently or?
We have rota, but obviously like the other centers, we don't use that sort of every day.
Yeah, unfortunately.
Yeah.
Cost because
obviously it's the cost plus the fact that you need to put in that much extra effort. So I think that's the limitation, like most cath labs in the rest of the world. I think that's going to be a limitation.
I mean, I have to say that when we started out doing rotabur, it took a lot of time for our nurses to get slick at it. But actually now, if we're doing rotabur, it's very easy for our nurses to set up a cocktail and the device. It just takes a matter of minutes.
I couldn't agree more.
Not advisable if you do once or twice a year, then that's going to be a problem for everyone. The staff and
I think if you're going to do it,
we on average do about 2 or 3 per week. So the setup is actually very slick.
So Fahim, you are going to only do one.
Yeah, I think our nurses have become very adept. So we're going to do an IVUS and see what it looks like, and keep the option of a 175 open. Let's see what it looks
on
like on
IVUS
IVUS.
is going to tell you do it or don't do it anymore?
So if we think that the calcium is broken down to a reasonable level, I think that'll be one indication that we can sort of go ahead and proceed with the dilatation. Obviously, if the IVUS doesn't even cross, then we clearly have a problem and we have to do a bit more.
You
So
mentioned
the rotor wire is still in
was
place.
like
Bring down, please.
25, 30%. So was there any thought of
30%,
having any
yeah.
support with the balloon pump or?
So again, so the IVUS isn't really crossing. Well, balloon pump, we
Fahim,
we
are
have
you going in on the
an
rotor
inotrope
wire
on
or
standby
is
if we
it
need
parallel
to.
wired?
Yeah.
No, we're going in with a run-through wire.
Yeah. So I think we can sort of we are just about in the lesion now, and it's not easy to cross the IVUS at this point.
IVUS catheter isn't
So why don't we do a
passing
pull back
will be
here?
an
Yeah.
indication
So let's
that
start
you've
recording.
outside your burr.
I think you need to look at the
So,
diagonal
recording,
as well
please.
to find out how much disease is there at the ostium.
You've still got
Sure.
napkin ring calcification there, actually.
Fahim, can I ask, is this an extra support rotor wire or a floppy?
It's a floppy.
Yeah, because quite often in cases like this, when eccentric calcium, I tend
Would
to
you use an extra support here?
I usually
Mohamed?
do because it gives me that extra bias toward
Okay.
the lesion.
Good point. That's a good point.
Should we try with 3.0 or do you want to?
So you're going to go higher bar now?
With 3.0, don't we?
I think that we have both options. I mean, one option is to try dilating it with a 3.0 NC. Another option actually is to upsize the burr and see if that improves things. What does the panel suggest?
Sohail, what would you do?
Stand by the 175.
I mean, looking at the IVUS...
I must say, I'm inclined to put
I
a
was
3.0 and then
then go,
palpate the
so-
lesion.
Napkin calcification in the proximal vessel. I mean, the reason the IVUS isn't going is that there's further calcification downstream from where you burred, probably. So I would be tempted to upsize the burr now to 175. If you're 6
175.
bench,
Yeah, I would probably do that
175 is
too.
probably
To
what
take
you
out this
might
one,
want to
you check the one.
One of the risks of using...
Yeah, I think that's sort of what we are.
Yeah, sorry, one of the risks of using a non-compliant balloon at this stage is probably perforation.
Check the other
Because
one.
you're going to have a resistance on one side.
Yeah, exactly.
The only saving grace is on the inside of the artery, which is a little
See
less
the
resistant
distal
on the
one?
outside. But there's that risk.
Okay.
Yeah.
Okay. Okay.
The panel
Right,
opinion
so we
is
set up
that you
the
should go with the
1.75
higher
So,
bar instead of going with the balloon.
One thing that has
Okay.
I don't
All
know
right.
if
Well,
it's
we'll
available
listen to
is
you
the
guys.
scalp.
That's what we're going to do.
Angiosculp, I think that I'm not sure whether it will go easily down.
No, I mean, but in
the
terms
angiosculp
of
may
if you're
not-
using the rotor.
Yeah,
you
It
can
may
use
not
the
go.
scalp.
Yeah. Sure. I think the big issue with the angiosculp will be that is it actually going to cross?
Yeah,
And I think
that's
that's a
what
fair
think.
point that, you know,
It's difficult to cross.
yeah. Yeah.
What about having another wire down the vessel as suggested? I mean, you can put another wire beside the original wire and maybe, I mean, we sometimes go in with a floppy and put the device on the floppy, the balloon or the IVUS, and that goes as Omar is suggesting, rather than use the heavy support wire, because that sort of pushes your balloon or device towards the edge, which holds it back. So I think the floppy wire is not a bad idea. I mean, you
So
need
we
to-
had the rotor wire acting as a sort of a semi-buddy wire, and it's not crossing.
Fahim, you're having to
I think
open
we are
another,
committed to
rotor
use a
kit
bigger
here,
size
right?
burr.
Fahim, can I ask you, do you
sorry,
have
say it again?
lots of money? Because I noticed that you've changed the whole system
Do
rather
we
than
have,
just
do I
taking a
personally
burr.
or?
You want to waste
Yeah, I think those are.
We have very generous sponsors. Aircon.
Okay.
But I think
But I think the
both of
point
us
is
feel
valid.
that changing with Avanza at our age is sometimes a bit challenging.
So remember, you know, the bigger your burr, the more difficult it is to load onto the wire. And as you all get older, you really need
And
to
this is the most difficult part of the whole procedure, I think, and I'm glad Paul's doing it, not me.
Well, I was going to pass it to our sculptors, who may have much sharper eyes than me.
That's what fellows were invented for, you know,
Exactly, yes.
to put the balloon or burr on the wire.
And take the blame.
All right, so same thing, we're going to go in with the 175.
We're going to do the draw again.
Yeah, so we do our draw. It's dripping, as you can see. I think that you can focus on this. All right, let's pass that on to you. So again, 160 again. Right? That's it.
Off Mac. Happy?
Okay.
Off
Right,
Mac.
let's put the flip back over there.
Yeah, I want to see the pistol line as well.
Why is
I
that?
haven't used that balloon. There is a balloon which goes up to like 40 atmospheres. People have used that. I don't know how effective.
It's called the OPN balloon, but the OPN balloon will not cross.
That's true. Yeah, it's probably bulky.
Actually, it has got a bigger profile, so it's, you know, we use it in proximally, and we have used it once or twice.
You always worry when the
You
company
need a
recommends a
special,
pericarditis in cases
inflation
case
device
for the
for
balloon.
that
Worse
as
than nausea.
Yeah.
Okay, happy? We'll just loosen this.
Okay. So the 3 steps again, sort of loosen up the system. Under fluoro, do a quick Dynatap, and we're ready to burr. So,
Ready,
Paul,
my draw?
you ready to fluoro for me?
Okay.
So again, pecking motion, tapping on the lean, that's where the IVUS got stuck.
Yeah. So you can see a little bit of deceleration on the burr speed, so that's probably the point that you need to focus on.
Yeah.
That's very important that you don't
Right,
need to
so we're going to
push
give
or
him a
don't
little break.
keep there for a longer time.
Yeah.
I mean,
No.
the other thing is, you know, what
The
you
most
really
important
want
thing is to
do
just
sort
peck
of
and
burr
let
for
it
10
find
or
its way.
15 seconds, and there's no rush in trying to cross that lesion. You know, take as long as you want.
So blood pressure is good, EKG looks good, hemodynamics is stable. We'll start the second run. Fluoro, please.
This is probably one of the advantages of the Rotaglide, which is not available in Europe. We don't have it in Europe. It's available obviously in Singapore and North America. In Europe, we use the our mix, which is nitrate,
Right.
verapamil, and heparin.
Yeah, that's
and
what
that
we do.
sometimes could lower the blood pressure and make the patient a little bit more bradycardic.
Yeah, we don't have
Yes,
that.
that's quite
You
true.
have to be careful with the Rotaglide because if you're
So blood pressure good, EKG good, we'll go for the third one.
you can't give them Rotaglide.
Okay, we have crossed, okay. Again, blood pressure good, EKG good.
So
we can
anyone
do a
in the
polishing
panel
run
would
now?
have considered putting a balloon pump with EF of 30%, triple vessel, circ was occluded, right has disease, LADs, calcified vessel, or
I think it's okay.
no?
Dynatap.
I guess balloon pump is completely out of favor, no?
Okay.
You can have it on
So we'll
stand
take a
by.
little test, just make sure that there's no puff, nothing of that sort. Looks okay. Go ahead.
Okay, feet to break.
Right.
Okay,
Ready?
I'm ready when you are. I'll show you.
You want to flow?
Yep. You have to open the one. Oh, I cannot change that. Is that it?
Okay, goes out. Yeah, we get the run through floppy wire again, please.
So you only have the sheath in place or you have the TPM in place too? Look at it.
No, we don't have the
We don't have a sheath either.
we don't have a transvenous pacer end.
Okay.
And the needle, please.
So that's what you do in even in the right coronary cases also, or just for the LAD?
In the right we'll tend to sometimes we'll do it without if the EF is good. If the EF is on the lower side, then a sheath end. Depending, I mean, sometimes we may even put a pacer, but a lot of times we'll just do it.
Yeah, it's increasingly rare to have a temporary wire.
And so far, touch wood, our experience has been, very good with that.
Fahim, can I say that for the last 8 years, I've only used temporary wire once.
Cranial wheel?
If you start at the beginning, when you test
Yeah, I
the
mean, that's
engine,
what-
you see a little bit of bradycardia, you could go a little slower. We haven't put the temporary wire for a long, long time.
Even for the right?
Sure.
Right or left.
And that's
to say,
interesting because you guys use Verapamil,
What's
so
interesting actually also is that if you become a radial operator, you don't go anywhere near the groin, and that includes putting a temporary wire in. So, at our institution, where a couple of us rota, my colleagues who are still predominantly femoral operators are quite keen to put wires in, whereas actually I tend not to. The other thing that I tend
Fahim, I don't
not
think
to
we're
do
going
is
to burr
put
again, so
Verapamil
do you
in
still want to keep the
cocktail.
rotor wire?
I think we can get the rotor wire out
Which is
now.
just made up of nitrates and heparin, and I find that
It's
the
a free
patient's
body
less
wire.
likely to run into problems with that. So.
Check that out.
So you're going to do IVUS again? Try.
Right, let's
Why not?
let's put the IVUS down and see.
It's a good test.
I think at this point, if it doesn't go, we'll take a balloon and try to dial it open.
Can we open the balloon anyway?
I think you probably still need a body wire to go around the
Feel
corner
15.
of that IVUS.
I think
Maybe so.
it's okay.
Maybe so. This time we faced a lot more resistance than the with the 1.5. So hopefully there's been some shaving of calcium.
1.5 seems
Sometimes it's-
small, so
This was the comment about
You're absolutely right. We
body wire.
I
The only
agree.
thing is to make sure you don't jail it to the stent because it's very flimsy and could come off.
Don't pull your wire back.
You could leave it and use it as a body wire.
Yeah, then one of the problem with the
Still got that clot.
starting with a bigger burr is that the chances of no reflow, and this patient might not be able to tolerate that much. If they start with a
in a EF of 30%, that's definitely.
I'm just saying if
All
they
right,
started
so-
with a
so
bigger
we are
bar, the
through now.
chances of
Store
no
that, please.
reflow would be a little bit higher than just
Feel
starting with a
15.
smaller bar and then gradually going up.
Open.
I agree. That's why we chose the
Okay,
1.5.
are we ready for pullback? Okay, pullback.
So start recording, please.
Drop down the Mac 1.
So as you can see, as I pull my IVUS, my guide gets sucked in, so I'm actually holding traction on the guide as we pull the IVUS back, and it's sort of really soft in over
Do you
here.
do it manually or?
So I'm actually almost disengaged. Oh, this is a manual pullback. Yes, it can be done the other way too. Do you guys, Mohana, do you do mostly mechanical pullback or?
No, for the eagle eye, it's much easier to do it manually because as sophisticated as the catheter is, give you the VH and the chroma flow, the pullback device is really the cheapest
Right.
device you could see.
Right. All right, so maybe if we can ask Dr. Ho to give us his suggestions. Can I get the C1 wire?
I think the IVUS pullback from the LED distal to the disease segment show that the vessel size is at least 3 to 5 in the distal LED segment. But as you are pulling back, you can see that there's a lot of plaque burden plus some arc of calcium. But I think there is been quite a good reasonable lumen gain from the rotablation 175.
So I just want interested in what the panelists would do at this point. Yeah, we
Looking
did
at
the
IVUS,
1.75 burr, and for a 6 French guy, we won't be able to upsize
I'd
anymore.
be tempted to take a non-compliant balloon up now and and see how that responds, maybe a 30 millimeter NC.
No, don't have it. Do you not have it? Can we open another? Open another. No need.
I mean,
So what's the consensus? NC balloon? Would you agree with that?
Yeah, I think so. I think that's probably a good option.
So I've just put a Sion wire in the diagonal just to protect it. Right, can we get a, what do we need, 3.0 or
3015.
3.15? Yeah.
So we're going to start with a 3015 balloon, NC. And meanwhile, should we check those ACT?
Fahim, I have to say, I struggle to understand this protection of a side by putting the wire down. What does it do?
You tell me, that's a good point.
Because, I mean, it makes us feel better that you put the wire, but if you're going to jail it, you're not going to do anything to it. The wire is not going to help you anything. I know people argue, say you know where the entry to it is. But in this artery, it's quite calcified and stiff.
I think there's an argument made that it,
Carina shifts is
there's
not
an
going to help.
argument made that it
Happy?
yeah, I think I'm happy.
Yeah. Here, I think there's also one issue. It's not just side branch. I think geographically, you know where you are, and I don't have to keep giving contrast to test things out. So I think there's a lot of extra benefit. This is only at 15 bar, but you can see the balloon is reasonably well expanded. But can we just go LAO cranial and just another view to make sure that...
So I think maybe the proximal needs a bit more.
Yeah, just to see that the balloon is indeed well expanded. Okay, so I'm going to go down.
So how
That's important
15 bar.
to look at the balloon in two views, come back to the
15 bar only. Just 15 atmospheres. So I just want to have a moderate pressure to see that the balloon indeed can fully expand.
So again, the balloon is sort of soft in. So I'm
Hit here?
yeah, I'm actually pulling on my guide. Yeah, let's go up here.
Okay, going up.
That popped out. Sorry.
Abandoned.
Yeah. Yeah, I just popped right back. So I'm not sure it will go in now. So, yeah, go up here. Yeah.
Balloon up. So this can go higher, right?
Yeah.
18?
18.
Yeah. 18 bar. Okay, and down.
So as you can see, the guide just sort of likes to
that's
get caught in.
very important to control the guide.
So it's always important to pull the guide out as you pull your balloons out. So I mean, I think then the next question is, so the balloon is still having a fair bit of resistance before it goes in.
So, sorry, which wire you have
Let me
run
just
through in
try
the
to
LED
advance a little
also?
bit more.
Otherwise, put a scope on.
So run through in the LED and we're through now. Run through in the LED, Sion in the diagonal. The reason for Sion is because it's green and so it's different and easier to see.
Yeah, but don't you think LED you might have used
So
it
we're up at 20 atmospheres.
with a better support because you may have trouble getting the stent down.
I think with one picture for thing.
I think you could. I mean, Bashir, I'm not sure that. Yeah, let me get the guide in.
Yeah, I think if you're able to get this down, hopefully you should be
I don't find that a really stiff wire would. Yeah. So I think maybe we push it in a bit more and dilate that little chunk up there.
Is that dissection or it's a branch?
I mean, the question is if you put a mailman down this.
Happy here?
Go up here? Yeah. So we're just dilating a bit more because there's a fair bit of recoil. And I think, for
18.
For fellows, certainly, I mean, if the winged balloon goes, your stent will go. If your winged balloon doesn't go, your stent may or may not go. Down.
18, 15 bar, 15 seconds.
So again, guide is being, I disengage the guide and then pull my balloon back. And then re-engage.
It's important to pull it back, but as soon as the balloon comes back, you need to push it, otherwise the whole thing can come out. Sometimes.
Correct. That's exactly what I did. So let's just see where this. It's a bit better now. The question is whether a stent will track or not.
So which stent you are going to use?
We're planning to use a Create stent, so by LV Medica.
Sorry, which one?
And we chose this stent because it's reasonably strong stent. It's the Create by LV Medica.
Oh, okay.
Do you have that in Pakistan?
No, I don't know. We don't have it in Karachi. I don't know. We don't have it back in Pakistan. So,
Is it stainless steel or cobalt chromium? What kind of stent?
It's a cobalt chromium stent. Okay, it's a slightly sort of it's a reservoir technology, a little bit like what we used to have in the Cordis old days when they have the Nevo. So it's a reservoir technology, no polymer, and using sirolimus. So they've got quite good data on the diabetic front, and I think we heard quite a lot of presentation from the Colombo group, and on the diabetes certainly have very good clinical data. But the beauty of it is it's got two markers on the stent, one in the proximal and one in the distal. In a heavily calcified lesion, it just makes life a little bit easy for us. So before we decide on that, maybe we just have some consensus of what size stents we should be using. Do you want to take a picture of it?
I thought we'll just look at the picture with the balloon.
Yeah.
So that balloon is 15 millimeters, so probably 2 balloon lengths. What do you think? So
how long
Yeah,
are you
the
using, sorry?
proximal won't be that long, right?
no,
20.
So I'm thinking
20 plus?
I'm thinking something like 30.
I'm thinking like 20 at the moment.
You know, you might,
What do you-
you might find it difficult to
What do you guys
keep
think?
around a
25?
30 millimeter
25?
stent around that bend. So
Yeah.
I think probably something shorter. I mean, you can always judge it on the IVUS
25?
in terms of length.
Fahim, do you
Field
have...
25.
And
was-
maybe
was
can
that
Dr. Ho
calcium-
tell us what the
So was that calcium there at the ostium or proximal left main? That at the end it seemed like kind of a die hanging or dissection, or was there? I didn't pay attention to that. You play this, run it again.
that's just calcium.
There's a
That's calcium.
Go to run number 2.
Yeah.
But
yeah.
you did dilated the balloon
this,
proximal to
just
the
one minute.
diagonal also, so you have to come back.
Yes. We will. So we
This is before.
yeah.
This is the beginning.
So we did dilate, and we're going to. I think that my feeling is that we need something like a 30. Judging by the balloon length, just to cover the whole plaque. Obviously, with a 30, the question of
25
trackability.
should be okay, right?
So what do you think? 25 or 30?
25? I think 25 should be okay.
I would go
We
with
can go with
30
25
because you did dilate
All right, so-
before, and you will probably be better off with 30, but you may have trouble
Yeah.
getting it down. What does the
Yeah,
panel-
that's going to be the issue, whether it gets
Probably
down or
hasn't
not.
touched
And
the
if it's
proximal LED, because the proximal LED is about 4 millimeter and
Yeah.
3 or so. Probably hasn't touched it. That wouldn't worry me. The proximal
But we
edge
probably
is
don't need
in
to.
a
We
perfect
probably don't need to
position,
touch it.
And then probably half balloon length.
You want 30? If your 30 doesn't go, we can go guideline.
yeah.
30?
Yeah. So let's go with a 30 or 30, 31, right? Yeah.
Okay, open.
So Create has some rather odd sizes, interestingly, but who's to say what's right or wrong?
How is the profile of this tent versus Zions or for Resolute?
I think it's probably comparable to Zion's. It may or may not be comparable to the Onyx. So we'll just have to see.
So do you want to focus on my hand?
So we'll try to see if the stent doesn't go with this, then we may have to use a
So
guideline.
it's got this carbon coating as well, so it's kind of black in color. Okay. Okay, can we go back to Angel? Let's see how it tracks.
Any comments or questions from the audience? Please go ahead. Your mic.
Okay.
Well, it tracked very nicely, so
Oh, that's good.
I guess that answers part of the question. So
We have a question
I think
from the
that's,
audience.
maybe go in a bit more.
What is
This
on?
looks good.
Looks good, right?
Looks pretty good.
It's
How about a
guided
pic-
design. Guided design.
I just have a question for the operators and the panel in general. I mean, where I trained, we did around 150, 200 rotablators a year in our center. and we would make sure that the rotablator burr would be inside the guide catheter before the foot hit the pedal when you're taking the burr out, even on Dynaglide. Because, I mean, I certainly had a case as a fellow, right coronary artery ostium, I dissected it during training because the rotaburr was in the ostium of the right coronary artery, and I pressed the pedal before the burr was
We
back
can
in the
actually
guide
go a
catheter.
bit more, but
So,
I
I
think
mean,
we
I've
miss it
experienced
probably.
that.
No,
Obviously, I was told off
Go in a
by
bit
my
more.
consultant, but that's something that was routinely followed in our center. Noticed both occasions the burr was inside the vessel, the Dynaglide was pressed, and actually the second occasion, 4 or 5 times, the burr was
Deploying
going
stand.
to and fro before it came back into the guide cath. Thanks.
Go to 10.
Well,
10.
yeah.
I mean, it sort of depends where your lesion is
Some potential still have a wire.
in coronary, doesn't it?
It's
If
cancer.
your lesion is quite distal,
I think we
you might
take
not
a new
have the
3
luxury of
and
being
post it
able
on
to,
new
to
3.5.
do that.
20 seconds.
If your lesion is proximal, so if you're dealing with
20
a
seconds down.
RCA lesion or
12
proximal
bar.
One more.
lesion, then I agree. I think,
Ready?
ideally you want
One more
to start burring
Okay, up again.
in the guide
How high
and
you
then
want?
pass it down.
12.
12.
Down.
For Dynaglide.
You mean on Dynaglide? Yeah. No, absolutely. Yeah. So you want to Dynaglide once the burr is in the guide catheter. Absolutely. Yeah.
That's what you do, Dr. Grettu?
I don't think that's necessarily true, because if you're treating a mid-course lesion, you're not going to be able to, you're going to have
Pull
to
it back,
Dynaglide
yeah.
back no matter what. It's releasing the tension from the system. That's all what you need to do.
3.5,
So you
3.5
Dynaglide,
NC,
just move
or
it a
you
little
want-
bit so you release the tension and you
I
can
think
take it out
3.5
without any
NC
problem.
for the proximal. What about for the distal? We
Maybe a
will-
little puff and just make sure it's not.
I just had a comment
Yes,
on
okay.
the
So just plot the
Create
proximal.
stent.
Yeah. And then I
We have
just.
the
Yeah.
Create stent in Pakistan.
So
We've
3.5.
reviewed- yeah, very much so. We've used it and we've enjoyed the fact that it has 2 markers
15?
on it. It passes through nicely with reasonable outcomes. And I believe it's very popular in Singapore as well as in Malaysia. There's a lot of usage for that.
Okay.
I mean, it certainly seems like a very deliverable stent, doesn't it? They created. I mean, it went round that bend.
It's very visible
like
as
a-
well, yeah.
Knife through butter. Do you have any
Yeah.
characteristics of the stent? What's the stent diameter? Its profile? Have you got any of that information at all for him?
The one thing about this, the sizing matrix is also quite attractive because the longer length they come in 46 mm. So sometimes this stance is quite useful for a very long lesion. And they also have stents up to 4.5, not 5.0. Comes in quite a good range of sizes as well.
And what about the sort of micron
Uh-huh.
thickness of the stent struts? Is it sort of 100 microns or less?
It's a similar to science, I think. No, I think it's similar to science.
Okay, so less than 100 microns.
So
We're having a little bit of trouble getting a new 3.5 NC into the stent. It sort of pulled a little bit of our system out. I may have to
put the other micro back in.
get the, it's going to be hard to get the dive wire in. I'm going to have to pull it out and maybe just use it as a buddy.
Pull it out. Right?
Yeah, pull it out.
Yeah.
And then,
Did you already rewire the
Would it
diagonal?
go without the body?
let's see if it. No, I didn't. But the stent sort of, with the balloons having a little bit of a hard time getting in. So what it did is sort of push the diagonal wire out, which is okay. I'm going to put it down as a buddy now and see if that can be. Can you come to the AP caudal view, please?
Yeah, sometimes if you leave, although you didn't
back
pull
to
it
the
out, but
cranial
leaving the diagonal wire there can give you some support to get it your balloon down. Once your balloon is down, then you can maybe pull it back.
Oh, that absolutely. That was the plan. But as I said, it sort of kicked the system out. So can I get the talk? I need the talker, please. The problem is that stents don't follow the script. They do what they want.
Well, it seems like your balloon was just not going beyond even the proximal edge of the stent. It didn't enter the stent. Look like that.
No, it didn't. Yeah, exactly. So we'll see. I mean, obviously, This wire may be a little bit messed up. The other option may be to take a 3/0 first and post-tilt this with a new 3/0 and then.
Are you using the Terumo AccuForce balloon here?
Sometimes inflating the balloon to 1
No,
millimeter
actually,
helps.
that's quite nice.
That helps it slip through if it's not going at all.
That would be if
No, you see, it was just a matter of basically, as you can see.
Go further.
it's a wire bias which really.
Okay.
Going up here?
Yep. Do you want to do a dry run to show them the marker? We're just going to do a dry run to show you the marker. Okay?
So maybe just
Yep.
12 there.
Yep. 12 bar.
No, it's just like
Slow
going
that,
one
please.
side. It's kind of scary when it
And down.
goes only on one side.
Go up here.
Okay. Balloon up.
12.
Okay.
Slow that. Down.
There is a small focal area at the origin of diagonal which is not kind of opening up on one side.
Okay. Happy?
No.
Any other
Push it in a
comments
bit.
from the panelists?
I think that just proves the point that this was not 110, this was a 111 actually, because the dent is exactly at the spot where the diagonal is arising, so the disease has to be there slightly distally as well.
Okay. I could just go to 12 for a second.
Yeah, I think it was
Okay.
111 because
12,
diagonal ostium was
12,
involved and there
slow
was
that,
lean proximal
down.
to that, I agree.
You can push it in a bit more. Both wires. You can push the other one in. Yeah. Careful.
More trouble.
Yeah. I'll just get the guy back in. Okay. Plenty of time. I think timing-wise, we're okay, right?
So I would say that maybe we take a 3/0 and go higher pressure there on that one spot right
Yeah.
where the diag is.
Take a shorter balloon.
Yeah.
Do we have a short 3.0 or 3.25?
I think maybe 3/0 because we're going to go really high.
How
high did you go?
high
Did you
pressure.
go on the
Fahim?
balloon? How
Just
high
listen.
did you go on the balloon? Pressure?
16.
Yeah, 16.
See,
16.
you could go higher.
Because I'm across the diagonal, I don't want to go very, very high. So we'll take a slightly undersized balloon there
Yeah.
and go at
3/0.
very high pressure.
Feel short.
So your workhorse wire is what, run
We're going to do a post-dilatation and then we're going to give you the...
Run through Cyan
Cyan
blue, sort of the mixed bag of things. So 3/0 NC.
Yeah. Okay. Yeah. Feel 8.
See the diagonal still there. How are we
What
doing
was
for
his
time?
creatinine clearance?
About 20 minutes.
Must be less than 50.
Creatinine clearance is about 30.
30, yeah. So the
EGFR.
yeah, the contrast
so-
volume,
Contrast is definitely an issue.
yeah.
Yeah.
So we're using 50-50 contrast most of the time.
Okay.
Happy here?
Let's go up here.
Okay. Going up.
20.
Yeah. 22. 22.
But sometimes using 50-50, you end up giving more because you don't see that well, so you have to. keep
22
giving
bar.
That's true. I mean, for the relevant portions,
I'll come back.
Yeah, I'm going to come back.
Yeah.
See, it just likes to slip out.
Okay, it's okay. Yeah, it's okay.
Yeah, just
Going up.
So how high did you go on this one?
22, 25.
25, okay.
25 bar, 10 seconds down. See the balloon cross and recross.
Just maybe whack. Let me put the wire down a bit.
Yeah.
So,
Oh, which is
but I-
obvious in the look.
Yeah, I mean, I think the issue will be whether the IVUS will cross with that, because there's a bend and there's an angle there.
Yeah.
So I think if I can try to let the balloon go down one more time,
Yeah.
it'll be a good thing. Just about here. Go up
See
there.
time? Okay.
Yeah.
One more time.
Yeah.
22.
Yeah.
Does it slip forward?
Yeah, but that's okay. I'll
Okay.
go up there.
We'll
Yeah.
go to 20 here then.
22 is good, yeah.
Okay. 22.
Store that.
Down.
Down. And then I think there's this one spot right at the diag.
That's a problem with short balloon.
Yeah. What resistance as it comes out. Go up here again.
Okay.
20.
We'll go up slowly.
Yeah.
Okay, got it?
Yeah, got it.
Okay. Okay, 22. Okay, and we
Down.
are done. Okay.
All right.
ECG is good. Blood pressure is all right.
The patient seems to be doing well.
ACT?
ACT, we can check one right now. We checked one a little while ago and topped up heparin. Let me get the guide in and you can see.
How much heparin did you give him in the beginning?
80 per kilo.
Why don't we just do an IVUS now?
Let's IVUS and
Yeah.
see. Let's see what it
Yeah,
looks like.
the origin of the diagonal, there is still some dent over there of the eccentric calcium.
Yeah, let's see what it looks like on IVUS.
Yeah,
Yeah.
I think that's probably a good idea actually, because you know if your areas are looking good on IVUS, you might just want to leave that. The risk
Yeah.
is, of course, that you might push that calcium
Yeah,
out of the vessel at this stage.
That's true.
15 minutes left.
Okay,
Right.
got plenty of time now. I got you one.
Okay.
Fahim, if you found the stent under expanded and still small lumen and the balloon is not doing much, what would you do next?
Mm-hmm. Yeah. We might try an OPN balloon, which is the sort of super high pressure balloon. Obviously, with so much calcium,
Bring down.
you worry. You worry about the the risk of perforation.
One
Yeah,
way
it's
of overcoming
sort of
this,
a
of
ba- I think
course,
it's more of a
inflating a
bend issue
one-to-one
than anything
balloon,
else.
non-compliant to nominal, then going slowly and leave it inflated for maybe a minute or two. And sometimes changing the pressure up and
Yeah,
down, you
up
find it
and down,
cracks
that,
them.
that does help. Yes. Some people have actually tried two balloons together also, that does help as well.
The alternative, of course, we're about to publish our series, is using laser, which is not available everywhere. Laser for under expanded stent, it works very well. Use it with contrast or without contrast, and it's very, very
Yeah, laser we don't have access to lasers.
Yes.
It's hard to get it to go. We may have to just IVUS here.
Yeah.
So I think we'll just start IVUSing here. I mean, I think it's a bit hard. It's hard for it to take that bend.
Yeah, I think lower
Let's
part
see
is
what
well
what
expanded,
it looks
so
like
should
on
be all
IVUS.
right.
Okay.
Do you think putting that diagonal
Yeah,
wire down as a
yeah.
body wire will help you?
It might. I mean, that would be another option.
Yeah.
So
But I think the main area is that
Again, it
next
sort of
to the
jumps
diagonal,
back,
so
and
we
that's-
should be able to see that.
yeah, so I don't know if we caught it or not. We may have to go back in. We can stop recording because we sort of jumped out.
But I think we probably can pull the diagonal wire out and just park it down as a buddy, can we?
Sure, let's
Yeah.
see. I may have to change wires because the
Yeah.
actually we're good.
Yeah, that's nice.
Yeah. All right, so let's give it one more go. Still a fair amount of resistance.
See the guide?
Show us the guide, please. And I think it's just a matter of that angle and obviously a stiff artery. Normally the artery bends to the well of the catheter, and here it's quite the opposite. So I think we're sort of, that's about all I can.
Why don't we start from here? Okay.
So let's start recording again, please.
Looking up for 25 OPM and 30. Short.
So this, maybe I can have Dr. Ho to
Comment
comment
that.
on this.
I think it's quite. I mean, the views that you got. I think this. It's hard to comment for him because I don't see the dent in the diagonal takeoff. But from what I measured just now, the media to media, in the proximal section, you probably can go higher, maybe with a 375 or 4 balloon.
Okay.
I think distally, the EM that we measured was about 4.0, so you can go with a 3.5 NC balloon distally.
Distally.
Yes.
Okay. All right.
Should we try an LPN?
I think you can try OPN as well to crack the dent.
I think that maybe I was thinking a 3.0 OPN just at the
3.0 or 2.5?
2.52. I mean, 2.5 might just be easier. Either way.
Feel?
I think because the vessel there is huge, so
Yeah.
a 3.0 would be at least give us a meaningful.
Okay, 3.0.
Yeah.
2.5. Okay, 2.510.
What do we have?
2.5.
Okay, give us
Okay.
that. Then.
So
So
what are you
the
gonna do
OPM
now?
balloon comes with its own deflator. Okay, so
So you're going to use that.
We're going to take an OPN balloon and try to dilate that mid-stent.
What size OPM?
Yeah.
Guru?
no, we're going to use it now. We're
3.0
going to use
or
a 2.5
3.5?
by 10. Okay, we use. Yeah. So we're going to just focus on doing this because I believe the satellite needs us to wrap up in the next few minutes. So we're going to quickly do this and demonstrate how we get this OPN balloon down. Okay, and then we at least have the chance to actually do a final shots of the coronary arteries before we actually say goodbye to you guys. I think this case a lot of discussion point. I hope that there will be a lot of things that we can talk about. Heavily calcified, calcified artery, renal impairment. This is
Yeah.
where it got stuck, right?
No,
Yeah, so
definitely
this
it was
is
a
exactly
very
the
interesting
spot. So
case
let's go up
and
here.
A lot of learning points.
Yeah.
Okay.
Well, we didn't do it, and we couldn't get it done in 5 minutes. That's for sure.
Okay, balloon is up. So this is at
Fahim, on the
35
last
atmospheres.
IVUS, did you measure the
And so maybe if they
cross-section area
if they can
diameter?
show. I'm sorry.
On the last IVUS, did you
Maybe
did you measure
Dr.
the
Ho can tell
cross-section
us the
area?
cross-sectional
Yeah.
area.
So is this 3.0 balloon or a 3.5?
No, this is actually this was a 3 or 2.5? 2.5.
We chose 2.5 because that's we have 2.5 or 3.5. 3.5 would be too big. And at 40 atmospheres, I think you have to be careful not to
Maybe-
do too much damage.
But that's
I'll
what I
come
was
back a
asking
little
about
bit
the IVUS
and
because
whack it
if-
one more time.
I mean, this could go up and looks very nice, but it's probably not touching the
Happy with
stent.
that?
Yeah, but I think that we may go offline. Go up here. We may go offline. We may go out with a bigger balloon. One of our concerns is that a 3.0 may not even go. So we're up at now 40 atmospheres. So at least we know that we're getting some expansion there. Down.
If
Yeah,
we
just
go
go up
offline, I really want to thank for this excellent case, great learning points, and I'm
40.
sure.
40?
No, thank you for having us,
will
and
be able
we'll
to
try
do
to give
that.
you a shot, and then down, please.
Yeah, sure.
Okay.
Give a big hand for a very difficult case for them.
So why don't we do a final shot?
Okay, let's do a final
Get the
picture.
blue now and do a final shot. We're just going to give you a final shot angiographically,
sure.
and then we obviously will do the IVUS and optimize the stent further. Get a guide. So contrast load here is roughly about 70 to 80.
Just get that out and then just go ahead. Actually,
Yep, actually it's not bad.
and it's that bend, right after the septal
Yeah.
across the diag. Maybe one view in the, should we do an areocranial? Freeze that for. I think distally and proximally we're quite good. The mid-stent, there's that area that's
Yeah,
perhaps
that's the
slightly
area just before
underexpanded.
the
We'll probably
diagonal.
go back in
Yeah.
and just blow it up a
We'll-
little bit.
We'll whack it with a 3.0 OPN now and sort of just try to optimize it a little bit. Heavily calcified lesions, that's the issue
Yeah.
with it. Sometimes no matter what you do, you cannot get the best expansion. But hopefully this was a learning case for everybody, in terms of
Definitely.
decision making
It
and
was
thought process.
A very difficult case and done very nicely. Thank you very much. Really appreciate Paul and all your team.